Hi, today I'll be discussing two patient case studies and how I would approach their care as a nutrition professional. The first patient is Louis Ballinger, a 39-year-old male admitted for chronic bilateral lower extremity lymphedema, a stage 2 lower extremity ulcer, and possible cellulitis. His medical history includes class 3 obesity, hypertension, hyperlipidemia, arthritis, and recurrent cellulitis. Factors contributing to Lewis's condition include environmental, genetic, and dietary influences. Environmental factors include limited mobility, wheelchair use, living alone, and needing assistance with activities of daily living. These factors can contribute to poor lymphatic circulation and delayed wound healing. Genetic factors include a family history of cardiovascular disease because his mother died from heart disease at age 38. Lewis's diet includes healthy choices, however, processed foods such as deli meats, pretzels, and desserts may increase sodium intake, which can worsen hypertension and fluid retention. Lewis's medications include simvastatin, lisinopril, esomeprazole, and Levsin. His pharmacotherapy supports the need for a low-sodium, low-fat diet to improve cardiovascular health and manage edema. Because he has a chronic ulcer, his medical nutrition therapy should also include increased protein to support tissue repair. Lewis is 70 inches tall and weighs 376 pounds, giving him a BMI of approximately 54. His estimated needs are approximately 2,500 to 2,800 calories per day, 100 to 110 grams of protein per day, and 2.3 to 2.5 liters of fluid daily. Compared with the chart recommendation of a low-sodium, low-fat diet, his prescription appropriately addresses cardiovascular risk, but additional protein should be emphasized for wound healing. Weight bias is not clearly documented in Lewis's case. However, there may be implicit weight bias because obesity was frequently emphasized while other factors were less emphasized. As the nutrition professional, I would discuss this with the healthcare team by recommending a weight-inclusive approach and using first-person language. I would encourage the team to focus on wound healing, mobility, and overall health outcomes rather than weight alone. Using motivational interviewing, I would ask questions such as, what changes feel realistic for you right now? And what concerns you most about managing your health? My focus would be reducing sodium intake, increasing protein intake, improving wound care, and supporting physical activity as tolerated. The second patient is Ben Johnson, a 22-year-old male admitted with newly diagnosed type 1 diabetes mellitus, presenting as diabetic ketoacidosis or DKA. He presented with severe hyperglycemia, dehydration, nausea, vomiting, abdominal pain, polyuria, and excessive thirst. Environmental factors affecting Ben include limited health care access, financial concerns related to his insurance, living independently, daily alcohol use, and frequent marijuana use. Genetic factors include a possible family history because he reports his mother takes medication for diabetes. His diet consists mainly of sugar-sweetened beverages, fast food, pizza, chips, and alcohol. Ben received intravenous regular insulin and insulin bolus and dextrose as needed for hypoglycemia prevention. This pharmacotherapy relates directly to his nutrition care because insulin management requires consistent carbohydrate intake and diabetes education. The clear liquid diet ordered during DKA treatment was appropriate. After stabilization, Ben should transition to a consistent carbohydrate diet with carbohydrate counting education and blood glucose monitoring. Ben is 6 feet tall and weighs 202 pounds with a BMI of approximately 27.4. His estimated needs are approximately 2,300 to 2,600 calories per day, 92 to 110 grams of protein per day, and 2.8 to 3.2 liters of fluid daily. The chart recommendation was appropriate during acute DKA treatment. However, long-term nutrition care should focus on diabetes self-management rather than weight loss alone. Weight bias may have been present because weight loss counseling was recommended during an acute DKA admission. The focus should have been on stabilizing glucose, managing insulin therapy, hydration, and diabetes education. As the nutrition professional, I'd recommend the dietary healthcare team that treatment goals prioritize glycemic control, nutrition education, and healthy behaviors before discussing weight management. Using motivational interviewing, I'd ask Ben, what concerns you most about your new diagnosis, and what changes do you feel ready to make? My focus areas would include carbohydrate counting, reducing sugary beverages, improving meal consistency, and learning insulin management and reducing alcohol intake. One evidence-based strategy to decrease weight bias is using weight-inclusive, patient-centered communication. This means focusing on health behaviors, medical needs, and quality of life rather than body weight alone. One article in 2025 explains that weight stigma can negatively impact healthcare relationships, quality of care, and patient outcomes. Educating healthcare professionals and encouraging respectful communication can help reduce weight stigma and improve patient centered care. Overall, both patients require individualized nutrition interventions. Lewis's care focuses on wound healing, reduction, and lymphedema management, while Ben's care focuses on insulin management, carbohydrate education, and diabetes self management. Using evidence based nutrition therapy, motivational interviewing, and strategies to reduce weight bias allows healthcare professionals to provide effective and compassionate care.